Hello everyone. Welcome back to the course on rodent neurosurgery. So, last session we went through all the aseptic precautions that are needed and how to sort of drape and prepare the rat's head. How do we fix it? So today we will go through the actual craniotomy steps and briefly about how the cranial window as such differs little bit from the craniotomy per se. So today's steps is mostly on, I mean, the entirely on craniotomy. The next session we will discuss on the stereotactic, burhole preparation, twist drill craniostomy. So it's very important that you understand the general principle behind it. And as I said earlier, every experiment will be customized to the need to achieve the particular objective or aim of your study. So I am trying to grossly uh, try and cover all the general surgical principles that are involved in the craniotomy, which will be useful for you to switch and sort of improvise or expand the usage of all these surgical steps. So the aim is that you will be able to handle the craniotomy as well as the stereotactic techniques and then try and customize it as per your need. So today's session is entirely on the craniotomy and cranial window surgeries. So that's the outline. I'll briefly touch upon the exposure of the skull so that there is some continuity from the previous session. Then a little bit about the planning, mostly on the drilling techniques because this forms the workhorse and this is a very crucial step in the rodent neurosurgery, which is common. This step is common for craniotomy as well as stereotactic techniques. So one has to master this usage of drill. Then I guess around 60 to 70% of the work is done if you are good in using the drill. So there is a significant learning curve in using the drill, and as I suggested earlier, try and use as much as possible the cadaver dissections to practice your drilling before you actually use your subjects or the experiment rats. And then I'll try and cover the special scenario where the steps differ from the usual craniotomy steps. That is the temporal craniotomy, and the anatomy is a bit different, the positioning is different. There are a lot of things which are different from the usual craniotomies. Then I touch upon the cranial and spinal windows, which is actually the craniotomy itself, but then you don't really make a huge craniotomy, or and then the application is a little different from the regular craniotomy. So I thought I'll have a brief introduction of these cranial and spinal window technique as well. Okay, so with that, let's see how is it different from the stereotactic planning. So craniotomy planning, as I said earlier, you are doing a wide exposure of the skull. We can do sort of a limited exposure, but then it doesn't really add much if you are going to limit the length of the incision. So I guess the length of the incision, whether it is for stereotactic procedure or for a craniotomy, it's more or less the same. And those craniotomy, I mean the incision limits has been already discussed. So what I want to highlight here is the draping part of it. So what has been shown here is the opsite, which is a transparent adhesive layer which you can actually stick it on to the entire rat's body, and this is going to be sterile. So this sterile sheet on top of which you can start using the sterile drapes as and when required. So the idea behind having this impervious waterproof layer is that when we talk about asepsis, when you use the cloth material directly over the rat, and you will be using irrigation during the surgery. So when that happens and the cloth becomes wet, then the entire field is considered unsterile. All right, so the pathogenic organisms can easily get into the field. So it's always good to have this waterproof impervious layer, preferably usually it is opsite, or sometimes we can even use the Ioban. Ioban is again it's a plastic transparent sheet which is adhesive layer in which the betadine or the povidone iodine antiseptic agent has been impregnated. So that's best, and that is what we use in human neurosurgeries. So, but then I guess opsite will do the job, and over on top of this, if you are draping for a small animal, this should do. And that is the classical positioning for the craniotomy. And this head fixation, how do we fix the ear bar and how to fix the nose bar, what are the nuances in which the coordinates and targets can change, all that has been discussed in the previous session. So just to briefly recap, what has been shown here is the exposure of the skull. So one can use this swab stick to push away the pericranium. So as I said earlier, pericranium is a very thin soft tissue layer on top of the skull, and it's very important that you try and avoid using drill on this slippery pericranial tissue because it generally slips. That is one important thing, and moreover you need to sort of expose the surface landmarks of bregma, lambda and coronal suture, sagittal suture. So it's always good to expose the entire skull before you actually begin the process of craniotomy. So that was about brief recap on the exposure of the skull. And when it comes to planning, it's very important to sort of know which is the area that you would want to expose. And I have emphasized earlier that it's very important that you don't really try and open up as much as skull as possible, for the simple reason that you don't want injury to the areas of the brain which are not needed to be exposed or to be targeted. So it's always safer to know beforehand which is the part of the brain that you are going to expose, and the remaining part of the area of the skull is definitely useful in order to use the anchoring. And that's one reason why we expose the entire skull in rodent neurosurgery. Unlike in human neurosurgery, in rodent neurosurgery you need to expose the entire skull, though the craniotomy is only here because the remaining part of the area is going to be the anchoring screws. And if it's the electrophysiological experiment, you'll be using a lot of ground and reference electrodes. So there are various uses of these exposure which we will learn in the subsequent slide. So what has been shown here on the right hand side, you can see, and if you all remember from the previous session, this is the Allen's mouse brain atlas, 3D atlas, where the M2 area has been highlighted. M2 is the secondary motor area, which is an associative motor area, wherein it takes inputs from the sensory areas and other cerebellar and other motor network areas, and then feed it into the M1, where the final processing happens and then sends the impulses down the spinal cord. So one of the study that we are doing on Parkinsonism or epilepsy models and various other models, whichever model that you are choosing, you need to know which is the largest area that needs to be exposed in the craniotomy. For example, if your area is on, if your study is on barrel cortex in the somatosensory area, that's the area that you need to target. So you need to know the extent of the area that needs to be exposed beforehand. For example, in this study, we are sensor, the cortical surface array need to be implanted in this M2 area. So for that, we needed to expose that 8 millimeter area is the minimum exposure that is required. Over and above, if I remove the skull, then there wouldn't be space for me to put the ground and reference electrodes. There wouldn't be enough space for me to use the anchoring screws and stuff. So that's the limited exposure, and you need to know whether you really need to expose both the side of the skull. That's very important to know it beforehand, because the midline sagittal suture, that is the sagittal suture, this is lambdoid suture, and that is the coronal suture. All right, and that is bregma and that is lambda. So usually we don't expose the midline for a simple reason that there is a large sagittal sinus, venous sinus that comes in, and if it bleeds, that is really detrimental to the survival of the rat. They will go in for complication known as cortical venous thrombosis or sagittal sinus thrombosis, or even injury can kill the rat instantaneously on your OT table. So try and avoid this midline exposure as much as possible. I'm not saying it's impossible. It is possible to expose, and we have exposed many a time, but then it is prone to get injured because that part of the dura is adherent to the skull more than the rest of the area. All right. So you need to know, are you going to do only a right sided craniotomy or the left sided craniotomy? That is partly decided by the dominance of the rodent. So when we talk about behavioral experiments, we talk on something about shaping. So shaping is basically to determine which is the dominant hand for the rat or mice that you're going to use. For example, if it grabs a food pellet using its right hand, then it is right dominant. And there is a crisscross wiring from the brain to the spinal cord. So the left hemisphere controls the right half of the body, right hemisphere controls the left of the body, which this has been covered in the neuroanatomy session as well. So in during your training session of the behavioral task, you will come to know which is the hand that you're going to use it, and then based on that you do either left sided craniotomy or the right sided craniotomy. Or if your study requires bilateral arrangement, like in this case where we had to expose both the side of the skull, we had planned to do the craniotomy, which is called bifrontal craniotomy. The frontal bone anterior to the coronal suture on both sides was planned to remove. So that sort of idea and the exposure and the craniotomy plan has to be ready before you begin the procedure. So, and there may be instances where you may be using both surface electrode versus and the depth electrodes. So when simultaneously you're using then both the type of electrodes, then it's very important that you have a very wide exposure of the skull, because the number of ground and reference electrodes are going to go up, and then of course the area that are required for anchoring screws are also less. So it's very important that you pre-plan it, in the sense as to what is the entry point of your depth electrode. For example, on the right hand side you can see that these two are the depth electrodes entering the deeper subthalamic nucleus in the basal ganglia, and that is the surface electrode. So if your study involves electrophysiology, then you need to keep in mind that there will be a lot of areas which will be used for head stage, there will be areas for PCBs, and then there will be areas for ground and reference electrodes, as I said earlier, and you need to plan the entire electrodes with a rigid fixation. That's very, very important. So that is the reason that you need to plan accordingly. If you're using the depth penetrating electrode, sometimes you may be using the drug delivery cannula along with the cranial sensor, so plan it accordingly. So these kind of planning and the objective needs to be ready before you start the craniotomy procedure, because once the craniotomy is done, it's very difficult to undo the steps and go back and change your strategy, and that rat subject will be of waste, so we need to be really careful before you begin the procedure. So having said that, do we really need to use the coordinates? And I would suggest it's very important whether it is a micro surgical procedure like craniotomy, or it's a stereotactic procedure like placing a burr hole. Both the instances I would definitely recommend to use these stereotactic coordinates for a simple reason. The area that is exposed need to be in the center of your field. It is not enough that you do a craniotomy and the cortical surface target is one corner of the field. Then the edge of the bone is going to hinder the various attachment that is going to come later. For example, let's say if you want to insert drug delivery cannula, all right, and you can see here, let me use the pointer here. So as I said earlier, if this is the craniotomy area that you have chosen based on stereotactic coordinate, then you can make sure that the drug delivery cannula is right in the center, or if you are using electrode, the surface electrode is right in the center. So centering of your the experimental tool, the ultimate tool that you're going to use, be it an electrode, be it a delivery cannula, be it an optogenetic stimulator electrode, fiber optic cannula, n number of peripherals that you're going to use, you need to plan it in the center of your craniotomy, and that center is based on the coordinate. So if we don't use the coordinates, and you generally do that sort of a craniotomy which goes way beyond, and if your the end peripheral device that you're going to use, if it comes in the edge of the craniotomy, that's going to be a big hassle for fixations to come in, and it is sort of damaging as well, where the bleeding, if it's from the edge of under the bone, it's very difficult to arrest it. So I always recommend that you plan the craniotomy such that the electrode or cannula or whatever end effector that you are planning to use will come in the center of the craniotomy field. So that's the reason why one would generally use the stereotactic coordinates. And once you determine the bregma and you know the coordinates, and accordingly you develop the final target coordinate onto the skull. So this stereotactic principles and planning the coordinate all has been covered in the previous session. So once you decide where to open up the skull, then the next very important step is the drilling. You need to remember that skull is a thick structure, and underneath it there is a jelly-like structure of brain. And on in between the skull and the brain, you all will know that you all remember from the previous session there are n number of cortical veins and arteries. These are very thin, delicate blood vessels which are easy to get damaged, and before you even begin your experiment, the rat either will die from the direct injury, or it's going to develop brain swelling, and then later in the recovery time we might lose the rat. So unless until you master the usage of drill on the skull of the rat, you are going to face a lot of problems with the experiments. So I would say it is very, very important to practice on the cadaver and then take it forward. So you need to also to decide which type of drill you are going to use. On the left hand side is the dental drill, which is popular because of its smaller size, smaller hand piece, easy to handle. But then there is a disadvantage, is that it is difficult to mount it on the stereotactic adapter as seen on the right side. On the right you can see that this coaxial system of drill has been mounted on the stereotactic apparatus. But then it's not that practical. For example, you will not be able to see the skull which is in front of the adapter. But nevertheless, for a beginner, when you need a little more training, it is always safer to use this sort of adapter, and where you can use micro manipulator which is in the stereotactic system, which can drive in axially up and down without any extra movements. But then the biggest disadvantage is that you will not get a haptic feedback. That is, when the skull is through and it is entering the radio, there is a sense of giving way. So that sort of tactile feedback is very important to stop drilling. So that by practice you will be able to do it with this as well. And then for to use this particular system, you need to make sure that the head is fixed rigidly without any dorsoventral, that is up and down movement of the skull. Because if that is going to happen, then there is a sudden plunge when the bone is drilled and when the extradural space is reached. So it's very important that either you use these adapters or use a freehand technique to drill. It's very important to know when the the depth is reached or when the dura is reached. It's very important that you don't puncture the dura, because once the dural puncture is done with the drill, then it is understood that the brain is injured under the area of the dural puncture. Alright, so These are two type of the drills. So, but then how do you decide the size? Generally, the diameters is pretty much standard. It is between zero point 0.6 to zero point 0.8 millimeter diameter. So it is a micro drill, and these are the examples that how you make burr holes before any sort of surgery. And it's very important to practice this particular step, because these are important both for craniotomy as well as for stereotactic surgeries. These are the holes for the anchoring screws. And if you all wonder why these screws are used, these screws are used in order to anchor the equipment or the interface device that is going to come on top of the skull of the rat, be it a drug delivery cannula. So that will go through this bigger burr hole, and once the, or for that matter, even if it's a depth electrode that you're trying to pass into the brain substance, once it goes in, you want it to stay within that area. And it's not enough to just put dental cement just around it, because that's going to, the rat is going to pluck it out. So in order to get a rigid fixation of any implant that you're going to do, we generally use these anchoring screws. And it's very important that you match the size of the screws with the drill bit. So here I've taken an example of 1 millimeter diameter screw, which is around 2 mm bigger than the drill bit per se. That's important for it to have what is known as purchase of the skull. So when you screw it into the skull substance, once the hole is smaller, the extra 2 millimeter diameter of the screw will make sure that the fit is good. Now that's called the purchase. It has threads on it, so that will have a very good grip onto the skull. And it's very important to maintain a gap between the surface of the skull and those screw when you finally screw it in, so that the dental cement occupies those spaces and the fixation is rigid. So this will form one unit along with the implant that you're planning to put in. So the idea of this anyway will be dealt in detail in the next session, where stereotactic surgeries will be discussed. But the idea of this slide in this point of time is that when you choose a drill bit diameter and when you choose a screw, you need to make sure this drill bit size is little smaller than the screw for good purchase. So there will be a little bit of trial and error when you don't get an exact size, which we all will go through. But then it's very important to make sure that once you put in the screws, there has to be good purchase when you tighten it. Okay, that's very important. Generally, this depth is based on the thickness of the skull. All right, so it shouldn't be too long that it will puncture the dura and injure the brain, neither too short that it will inadequately cover the thickness of the skull. So optimal size that we have come across, this is for the Vista rat that we were doing, and we came across this particular size, and with this you can always decide based on your experiment and other requirements. So once you know about the drilling, the drill part and the setup that is required for drilling, now you're good to go for drilling. So that is the skull which is exposed completely. So that is a bregma. So this is the parietal bone. So here they're doing a parietal craniotomy, and this can be used as a cranial window as well. So one need to there are different ways as to how the craniotomy can be performed, but the standard way of doing it is that better to go ahead with the making a groove along the line of the craniotomy. If this is your requirement for craniotomy, you don't make a burr hole straight in and then take a craniotomy and then do it. So that's the standard procedure in humans, wherein a burr hole is made and then there is a cutter which goes with a foot plate which goes all around and cuts it. Because the skull is so thin, it is sensible to thin it out further with the drill and then separate it from the surrounding skull. So as you can see here, this is the burr, all right, the drill burr. The tip of the drill bit is called burr, and the edges, the sharp edges on it called flutes, all right. So one need to know which way, when it rotating clockwise, you need to use the drill, in the reverse manner, so that it doesn't slip forward and then injure the neighboring structure. That's very, very important to understand. And either you can go straight perpendicular down onto the skull, or the preferred technique would be to use it in a slightly slant position where you can see the uh, tip of the drill bit and how it comes in contact with the skull. So with that, in a circular manner, you generally thin it out and then look for the separation from the edge of the bone. Then only we are going to lift the skull bone away from the dura. And that's very, very important. So with the video, I can show you all how this particular step is performed. All right. So here is a example. So this is a mice. Head has been fixed rigidly, and you can see, but one step is that the eye closure has not been done. This is one of the online version of video which we had taken. The eye has to be covered completely so that it's not kept open like this, because prone for injury. And this is probably one of the acute study where they're going to implant the drug delivery cannula. So the instead of making an incision, there's always an option of excising the skin flap, especially if it's an acute study and you really don't worry about closing it back. The easier way is to excise it, because if you make an incision, you need to make sure that there are retractors to hold the skin flap back, or you need to even take a sutures to keep it separate. And what they're doing at this particular step is to remove the pericranium. It's very, very important, and you roughen the skull so that the skull is rough enough for to hold the drill bit in place. And what you're seeing here now is the groove making, using the drill bit. This is the dental drill, where you can have a slant edge onto the top of the skull rather than having perpendicular. And once the groove is made, you check whether you can see that it's getting depressed. That means the skull is separated, that part of the skull is separated from the remaining part of the skull. And what has been placed here is the artificial CSF, and then try to gently lift up. You can see that the edge of the bone that is separated, and then with the Dumont microforceps you can lift up the skull. I mean, in a young mice, the skull is going to be pretty thin. So because of that, you may be able to lift it up that way. But then it may not be that thin in case of the Vista rat or older rats, wherein you need to sort of deepen this groove and make sure that it is completely separate from the edge of the bone. And that is made sure by giving a firm pressure on the center of the craniotomy bone, and see that if it is separate from the remaining part of the skull. Once it is confirmed, then only you are going to lift it up. And it is very important in that process where you elevate the bone table not to injure the dura. All right, there are many instruments. A flat dissector usually is used to keep the dura intact before you lift up the skull. If the dura tears along with the skull, usually you can see here there is this vessel there which can get injured, and if it starts bleeding, that part of the area which you actually wanted to study will get destroyed. It's called ischemic infarct or stroke. That can happen because of the iatrogenic. That is something introduced by the physician, or for that matter a person who is conducting the experiment. So that would affect the entire experiment and the outcome. So it's very important that you maintain the dura, which is a thick tough layer, but then bound to get injured if you're not careful enough to protect it in the step of drilling. So this is a very critical a step. All right. So once the craniotomy is done, so next important different technique that one need to know is the creation of stroke model, which is a little different from the usual craniotomy that you just witnessed. So a surface craniotomy is slightly easier to handle because it's right on top and the coordinates are easier, the position is standard, everything is standard. Whereas if you're trying to do anything below the temporal ridge of the rat, then the position is lateral. All right. So all the position that you use for parietal craniotomy or frontal craniotomy, the rat is going to lie on its belly, and it's a pretty standard position and it's easier to handle. The minute you want to handle these kind of arteries, or if you want to sort of expose the temporal lobe or the lateral surface of the brain, then the rat has to be placed in lateral position. Here what you can see is the middle cerebral artery occlusion model. There are various stroke models. One of the stroke model is that you inject an exototoxic drug into the area that you want to create infarct. Infarct, as I said earlier, is basically the part of the brain which is necrosed or dead. In a simple plain language, part of the brain will be dead because of the lack of blood supply which carries oxygen and glucose. So that is ischemia and that is infarct. Ischemia is basically a loss of blood supply. Infarct is the result of ischemia, wherein part of the brain is dead. All right. So what has been shown here is the middle cerebral artery. If you all remember from the neuroanatomy session, middle cerebral artery comes from the base of the brain. This is the top of the brain, all right, and this is the ventricles, and this is the vasculature which goes from below upwards, and that's the middle cerebral artery, and it ramifies into different branches and then supply all the cortical brain tissue. So if you want to create a stroke, then the best is to coagulate using the bipolar cautery, not the monopolar. As I said earlier, this has been discussed again. So you only the current will be between the two tips of the bipolar forceps. Whereas if it's monopolar, there usually a sink of electrical field around it, and it will injure or affect the neighboring vessel as well. That is why it is preferred always to use the bipolar forceps to coagulate. So how do we expose this? It's pretty tricky because it's in the base of the skull, and when you expose that, you are very close to the area of eye and the ear. So there are certain landmarks that we need to follow, and what is very close to this artery is the inferior cerebral vein. So let's see how we can do this, but use this particular model. And I'm trying to cover this model mainly because the craniotomy that we just discussed is not going to be useful for this particular model, and it's pretty different. So as I said, the rat has to lie in the lateral position, all right, and the area that we're going to use is between the auricle and the eye. So the rat is lying on its lateral side with the side up. If for example this is the left side of the rat, because the rat is right dominant and you want to induce the infarct and create a stroke model in the left hemisphere, all right. So what is known as temporal craniotomy. This temporal craniotomy is pretty different from the parietal or frontal craniotomy we just discussed. So the incision for the temporal craniotomy is the midpoint between the eye and the auricle, all right. So that's the area that you're going to make an incision. So we need to remove the hairs and prepare the area and drape that particular area, as we just discussed in the previous session. So that is the area of the bone from which the flattened surface of the skull, which is the top of the skull, is medial, and below that is the temporal bone. So there is a thick ridge on the edge of the top surface of the skull, which is called linea temporalis, all right. So the entire craniotomy is going to be below the linea temporalis, and you can feel another bony ridge called zygomatic arch, which is closer to the maxilla or the upper jaw of the rat. So between these two bones is where we are going to create a cranial window or making an opening. So you make a a vertical incision like that. So the rat has been draped. You can see the plastic thin sheet over the auricle, and the eye has been stitched here. As I said, as your operative field is closer to the eye, it's always wiser either you stitch it or at least protect it with the eye ointment and keep a wet, moist cotton on top of it so that it doesn't injure the cornea, which is pretty sensitive. So in this scenario, we have stitched the eyelids so that the operative procedure doesn't interfere with the eye. So once the incision is made, you will expose what is known as temporalis muscle. So that is the what do you say, the biggest difference between top of the skull versus temporal craniotomy. That is parietal craniotomy versus temporal craniotomy. That you come across a very thick muscle soon after the skin incision. So we need to split that muscle to expose the temporal bone. All right. So here the muscle has been split, and you will come across in the depth what is known as coronoid process. Okay. So that is the zygomatic arch, and that is the linea temporalis. Medial to that or closer to the midline away from the linea temporalis is the flat surface of the skull. So that is your upper limit. Linea temporalis is upper limit and zygomatic arch is the lower limit. So once you split the muscle, now what you see is the your craniectomy edges. So craniectomy word is used instead of craniotomy because you're not going to replace the skull flap here. Whereas in parietal craniotomy, once you make a window, for example, you're implanting a surface electrode, you can replace the bone flap, then the word craniotomy will be used. If you are removing the bone permanently, then the word ectomy. Ectomy is cutting off. So craniectomy terminology will be used. So anyway, in any terms, you're basically trying to expose the area of the brain below that particular area. All right. So posteriorly, that is backward, that is there is auricle. In front, you have eye. Lower down is zygomatic arch, and upper limit is linea temporalis. So you need to drill in this particular area. So once the drill is done and the bone is removed in the similar fashion that we discussed earlier, then you will expose the dura there. So once you expose the dura, if you remember the first picture I had shown, the middle cerebral artery comes from the base. So as you know that this is the lower surface, lower part of the animal, that is towards the belly, this is towards the head. All right. So it comes from the base of the skull, that's the middle cerebral artery, and there is another landmark which is little difficult to expose, and if you have that, that's pretty good. Olfactory tract, that's the pathway carrying the olfaction. So that's the surface landmark once you expose this area to identify the middle cerebral artery. Nonetheless, it's a very prominent vessel, difficult to miss it if you are following other landmarks correctly. Once the middle cerebral artery is exposed, you need to differentiate it from the vein that I just discussed, inferior cerebral vein, because that should not be injured or by mistake occluded, thinking that is an MCA. The ICV or the vein is perpendicular to the middle cerebral artery, which comes from the base of the skull. So once you recognize this skull, now you are good to expose the actual artery and the brain by removing the dura. If you remember from the previous slide, you can see a thin hazy layer on it that has been removed here. Dura has been opened and the vessels are exposed. So that is a vein, that's the artery. In humans, it's pretty easy to differentiate between vein and artery, but then in rodent, though it is a very small animal, it's difficult to differentiate between by the color of it. All right. So that's the MCA vessel, and that has been coagulated using the bipedal forceps, and it turns black to brown. So that is the classical MCA occlusion using bipolar coagulation once the middle cerebral artery is exposed by doing a temporal craniotomy. So this is a very important difference with the usual craniotomy, and I'm sure this craniotomy can be used for many other approaches to the various brain structures. All right, so this is temporal craniotomy. So once that is done, you need to, once the coagulation is done, you will be transecting it again to make sure that there is complete division of the middle cerebral artery. All right, and then the surgical wound is closed either by stitches or by staples, and then the eye suture is open, and you all see that, and that is intact. All right, so another major additional surgical procedure that accompanies creation of stroke model is the ligation of carotid and middle cerebral artery. So it is always combined uh, to achieve a good stroke model. So what I'm trying to say is that it is not enough just to um, expose the middle cerebral artery and occlude it with bipolar forceps. What we are showing here is the neck dissection. You make a midline incision from the jaw, lower jaw to the sternum. So this is in the supine position. All right. So ideally this is done first before we actually do the craniotomy. That's the supine position where you can see the skin has been opened up widely, and then put a stay sutures to keep the structures in view. And this also have a significant learning curve which can be mastered by doing a cadaver dissection. What we're doing is to, after exposing the salivary glands which come superficially, you go deeper right next to the trachea. What you're seeing in the middle is the windpipe. Next to that is the carotid artery. One side it is occluded and one side it is ligated permanently. So on one side there is a temporary occlusion wherein you take a loop of the silk suture and then tie it down, but don't clamp it completely, and then close it for the later half of the surgery, and then close the wound. You will be revisiting this once the middle cerebral artery is occluded. This one side of the artery is required to make sure that um, the general blood supply of the brain is maintained. It is impossible that you take off both the carotid, because that will cause bilateral infarcts, which is detrimental to the survival of the rat. So one side you permanently occlude it, and the other side you temporarily occlude it for around 40 to 45 minutes, by which time you do the middle cerebral artery by doing a temporal craniotomy. So this combined carotid and middle cerebral artery occlusion is very important to do it, so that the collateral supply, let's say if you've done the occlusion only for the middle cerebral artery, then the other side of the carotid artery sort of comes and compensate for the loss of the middle cerebral artery occlusion, loss due to the middle cerebral artery occlusion. So that is the reason why you also do a ipsilateral carotid artery occlusion along with middle cerebral artery. So this is one extra surgical procedure that you need to sort of practice if you are trying to consider the stroke model, which is widely used rat model for various experiments. So briefly, I'll cover the cranial and spinal windows, because anyway we are discussing the craniotomy. Here the only extra few steps that are needed is to fix the cranial window apparatus or the setup to use it for your various other experiments. So generally this is used for 2-photon microscopy, which is coming in big way now. Most of the many experiments are used using this particular technique of optogenetic stimulation, or for that matter 2-photon microscopy, where you can watch the live brain in action. That's the beauty of this 2-photon microscopy, where you can actually see the neurons in action, where the fluorescence lights up with the action potential. So in order to see that, you will use what is known as 2-photon microscopy, and for the microscopy to see through the different layers, you need to have brain being exposed and maintained. All right, so here there are various examples shown here. One is the cerebral cortex window. It only depends on the various stereotactic coordinates and the location of area of interest for study. If you want to study the cerebellum, you are creating a cerebellum window. by making an opening in the occipital bone, and this is the frontal cerebral window, and that's the spinal cord chamber. Where if you want to study the spinal cord, it's a similar technique, but then different in terms of removal of laminar plate, which we'll be discussing it in the next few sessions. And then you have olfactory bulb window. So there are various window to peer through the central nervous system in action. It's very important to know that these are also available as an option if you're trying to do the rodent experiments. So these are the various steps wherein the cranial windows are created. So as you can see, once the craniotomy is performed, it is filled with the artificial CSF. It's very, very important that the CSF is not leaked out, because you're planning to use the cover glass on top of it. You can't have the cover glass directly on top of the brain, because it needs a media to see through, and then you need to fix it to the edge of the skull using the dental cement or bone cement. So that's the extra few steps needed to create a cranial window. And what you can do is to have a sort of protective plug on top of it, where you can thread it, remove it, and you can reuse it. Or you can have a PDMS layer through which another anytime this sampling of the brain can be done, or neurophysiological recordings can be done. So there are the various options for cranial windows. Either you can have a cover glass with the artificial CSF, or you can have a protective plug through which the microscope can be used, or you can have a PDMS covering through which the brain can be sampled again and again, either to deliver the drug or to record the neural signals. The idea being that the brain is being exposed, and the rat can be allowed to recover from this stage onwards, and the brain is exposed all the time. Either you want to use the microscope or you want to deliver certain drug, the brain is available. All right. So it's very important that the superior sagittal sinus is left intact whenever you create the windows here, and that's pretty important. So that is the superior sagittal sinus that I was talking about. So this particular sinus, if it injured during the cranial window creation, that's very detrimental to the life of the rat. So these are some of the live examples. You can see that once the window is created, the microscope is brought into action to see various activity, and this is a 2-photon microscopy where the fluorescent dye has been used, and along the z-axis it runs, and then different layers of the rodent brain can be visualized, and then there is a readout of the calcium signaling that can happen, and you can even you can see the fluorescent activity in the areas of the brain which is active. So the rat is fixed, and there is a cranial, this is a cranial stabilization system where the microscope can be used as the rat is performing various activity. Even that option is available. So that is the advantage. And as I said, if you have a PDMS layer, you can even send a pipette and through it, and either deliver the vector viral agents or deliver any sort of drugs, excitotoxic agent, or you can even fix up a cranial window setup which can be used at a later stage once a rat recovers. So these are the various modifications that can be used, and this is just to cover the topic. You can also create various spinal windows similarly, but one need to design this particular plate that needs to be fixed on the bony structure. You can see the screws there, and then you will pour the dental cement on the side. So this sort of metal frame is required to keep the cranial windows as well as spinal windows if your study requires the repeated sampling or repeated delivery of the drug, or anything that requires a chronic extension of the study. So with that, we will cover we'll conclude today's session. So to summarize, we have covered the craniotomy, the basic steps involved in the craniotomy. And as I said, it is very difficult to sort of cover all the practical steps that are involved. I have tried to demonstrate and I've tried to explain the steps and principles that are required. But whatever said and done, unless until you all practice these particular steps on the rodent cadavers, it is difficult to sort of master those steps. So please go through this part of the session again and again and understand all the principles. Read up a little bit more to understand the various modifications and nuances of creating a cranial or spinal window, and then master the various craniotomy steps as well. So as I said earlier, you will have to modify all these steps as per the requirement, but the basic step of drilling, using the anchoring screws, using dental cement, all that is going to be more or less similar. Alright, so the next session we will try and cover all the stereotactic implantation. Now, implantation of drug delivery cannula, implantation of electrodes, but all of those procedures will have one common procedure which needs to be followed, and then it's only the implant that is going to be different and the location is going to be different, but the general principle behind all these procedures are going to be more or less the same. So let's try and cover the stereotactic implantation steps in the next session. Thank you.